and welcome to Askimo TV. I'm talking today to Dr. Alessio Agostinis. Dr. Agostinis is a highly specialist clinical psychologist based in the UK and is the principal and owner of CTT International, specializing in bespoke psychological consultations, therapy, and training. Hi, Dr. Agostinis. How are you?
I'm good, thank you. Thanks for me.
Dr. Agostinis, today we're going to be talking about post-traumatic stress disorder, or PTSD. So let's begin with, what is PTSD?
Post-traumatic stress disorder is part of a group of disorders under the umbrella of anxiety disorders. Is an atypical one in the sense that the anxiety that the person experiences is based to a past event as opposed to a future event, as is characteristic from generally anxiety disorders. The key features are, first of all, it might be helpful to differentiate also post-traumatic stress disorder from acute stress disorder. Basically similar, same symptoms, it's just that the duration of those symptoms makes it such that one is referred to as acute stress disorder and the other as post-traumatic stress disorder. Virtually same features. There needs to be a traumatic event, an onset event, which has to endanger an individual or someone close to them, and diagnostically has to elicit thoughts such as I'm going to die. People must be terrified of being at threat of death at a particular time. And that's a key diagnostic feature. So if you and I were in, say, a significant car crash and we saw a big truck heading our way, we would have a mixture of thoughts, cognitions, and emotions such as, oh, this is going to kill me, and feel as that might be the case. So that's a key factor, because unless the person experiences that, they do not meet that diagnostic criteria later on. Then, as a subsequence to the trigger event, so a life-threatening for oneself or for another, because the fear may be about oneself or that of a loved one, say a child or a spouse, or someone we see being hurt by. Subsequent to that, typically people will experience a number of psychological consequences. This will be things such as feeling as if they were back at that time. There is commonly known flashbacks, therefore, and these may be in the form of any of the senses. So there may be actual pictures, images of the event. There may be physical sensations related to the event. There may be taste, smell, any of the senses that really got affected at that time. So basically, when our threat response system went in overdrive and decided we need to do something to get the hell out of here, but we can't. Excuse the language. Typically, the first month following a trauma, it's not unusual to experience these symptoms. It's quite normal and human that our brain, having felt under threat, decides that it needs to turn the volume up on our threat response mechanisms. And so we mentioned some, such as this feeling back at that time, experiences to any sense, things we experienced at that very moment, almost as if we were back at that time, is very usual. In fact, one of the diagnostic criteria for post-traumatic stress disorder, or PTSD in short, of course, that people will have recurrent nightmares daily and at least 3 times a week by diagnostic criteria. Now, it can be either a nightmare, but often people will say that on awakening, they will experience a flashback, say in the middle of the night. So just to summarize a little bit, because there's lots of detail, but basically it's a reaction to an actual or perceived life-threatening situation, which then creates a persistent set of experiences related to that initial event. Those experiences tend to play out a bit like a broken record, the same fears, the same sensations, the same thoughts that that person experienced at a very actual or perceived life-threatening moment.
Dr. Agostinis, how do you treat post-traumatic stress disorder?
Okay, now the recommended treatment by guideline is something called, there are two main recommended treatments which have equal efficacy on the evidence base. The best treatments are cognitive behavioral therapy or eye movement desensitization reprogramming, EMDR in short. And basically, the first one is the most widely utilized one, although the second is catching up. And basically, is this idea that we need to very gently habituate, reteach the brain that we are not back at that time. And that's through a process called gradual exposure. So basically, is a bit like a training program. There's an initial assessment with a therapist that will take some history. So the history will include, tell me a bit about the event, tell me a bit about what went on, and more importantly, what did you experience at that time? All those factors we talked about before. Did you fear for your life or that of anybody else? Did you know or think you might die? What things have you tried so far? Because typically one common, however unfortunate response is that people will start utilizing drink, alcohol or drugs to try and block out these experiences. And post-traumatic stress disorder initially used to be called shell shock, with the war veterans coming back from Vietnam. And so there'd be a history collected, so a list of thoughts, feelings and emotions the person experiences in what situations. So if I was run over by a car and that caused me post-traumatic stress disorder, it may be that my target area of work is somewhere on the street, that I may need to very gently rehabilitate that person to think about going back on the street, to use some relaxation strategies and some imagery strategies to do what we call in-session imagery exposure. So to picture going back on the street, maybe then gradually build it up, imagining going back to the place where the accident took place, then setting a small goal to begin going on the actual streets, then gradually onto the closer to the place where it took place, applying some relaxation strategies, and basically a little bit at a time getting the person closer and closer to the same or as close a context they were in at the time of the accident. So the brain processes that information and not tell us that we are back at that time to try and protect us from extinction, basically. Did that make sense?
Yes, absolutely. Dr. Agostinis,
So,
just to...
treatment varies.
Sorry, carry on.
So our treatment varies. We have normally within the first month we talk about, as I said, acute stress disorder, and no treatment is required at that stage necessarily. There's a good body of evidence on something called debriefing. So a few years ago, after plane crashes, they used to send armies of therapists to see people after, say, a plane crash or natural disaster. And what the evidence suggests now, that actually eliciting the thoughts and the emotions and the memories very shortly after a traumatic event actually can lead to re-traumatizing the person. So debriefing is no longer utilized, but what it is utilized, there is some very basic normalization applied. So as people have these experiences, the thing we would tend to do is not get them to dig them out too early on, but to say this is quite a normal experience. It's called normalization. It will get better after a while, and give yourself some time. And if it hasn't resolved, then we would look at a therapeutic intervention. Now, normally, within 3 months, most post-traumatic stress has resolved, maximum to a year. Well, after 3 months, we normally look at perhaps starting some treatment to avoid the person getting too stuck into this threat response pattern.
Thank you, Dr. Agostinis. Thank you so much for talking to me today.
Thank you. Thanks for having me.